I am Brigitte BADER-MEUNIER, pediatrician, and I work in the referral center of pediatric rheumatology at Necker Hospitals. And I will speak about juvenile dermatomyositis with Maxime FRICHOT, physiotherapist.
Yes, I am Maxime. I'm physiotherapist in the pediatric immunology, hematology, and rheumatology service in the hospital of Necker for Malade. And I will talk about the place of the physiotherapy with the dermatomyositis.
So the juvenile dermatomyositis is a very rare disease in children. Of course, the muscle and skin involvement are the main feature of this disease, but it may present also as a more systemic disease. So key features are skin involvement. You may see here facial rash, Gauthron's papule, lesions of knees, and in more severe case, telangiectasia, edema, skin ulcerations, or diffuse poikiloderma. Second main involvement, muscle involvement, which presents as a symmetric proximal weakness, predominantly in the trunk, shoulder, and pelvic girdle. The muscle tenderness is inconsistent and often moderate. In severe forms, smooth muscles is involved and resulting in nasal voice and swallowing difficulties. So the diagnosis of JDM is clinical in the majority of cases, and here you may see the Euler classification in a child with a criteria classification for inflammatory myositis associated with either heliotop rash or contrast papules or thin. The disease may be classified as JDM. But some other clinical manifestations may occur. Fever is absent or moderate. Children may have symmetric arthritis involving large and small joints. I have put in red the difference between the children and adult forms of dermatomyositis. And first, the pulmonary involvement presents in 20 or to 50% of the children, is often asymptomatic, and rapid progressive lung disease is exceptional in children. Cardiac involvement is rare. Gastrointestinal involvement is a second characteristic of pediatric JDM, and it is a severe manifestation occurring mainly in vasculopathic JDM and presents as ulcers, gut perforation, digestive bleeding, or malabsorption. And finally, associated cancers are exceptional in children, conversely to what is observed in adults. During the course, calcinosis may occur, especially when in NXP2 positive JDM, and more rarely lipodystrophy. When muscle biopsy is performed, the histological features of JDM consist of myofiber perivascular atrophy, perivascular inflammation, and in severe form, you may see multifocal capillary loss with sometimes microinfarctus and focal myosin loss. This examination of muscle biopsy must be performed in expert lab, and immunochemistry staining have to be done. They show an hyperexpression of MIC1 molecules and hyperexpression of complements complex C5, C9. Myositis-specific antibodies are present in 60 to 70% of the children, and they are mainly anti-TIF1 gamma, anti-MDF5, and anti-NXP2 autoantibodies. The identification about 10 years ago of that MSR emphasizes the heterogeneity of the disease, and in fact we think that now dermatomyositis. There are several subtypes of dermatomyositis, and that it is not a single disease. For example, in NXP2 positive JDM, the main clinical manifestations are severe muscle involvement secondary to vasculopathy, contractures, bowel ulcerations, edema, while skin involvement is often mild. And calcinosis occur frequently in association with these autoantibodies. Second example of MDF5 positive dermatomyositis, children have often skin ulceration, arthritis, interstitial lung disease, while muscle involvement is often absent of milder. In this form of JDM, type 1 interferon is more elevated in serum than in the other type of dermatomyositis. So what tests are needed to diagnose JDM? Of course, you have to measure muscle enzyme, mainly CK and AST. The enzymes may be normal in about 10% of the case. You have absolutely to perform to search for MSA. You have seen that anti-NXP2, MI2, TIF1 gamma, MDA5 autoantibody are the predominant MSA. Muscle biopsy should be performed in atypical form of JDM, especially without skin involvement, and in case of other atypical forms. They may also help to the classification of this heterogeneous disease. Muscle MRI should not be performed systematically. It might be helpful in some atypical forms. And we have to look at some other complications of the disease. Pulmonary function test and lung CT scan are recommended at diagnosis in case of JDM. And of course, we have to perform cardiac echography and EKG to search for cardiac involvement. And now, how to treat the patient? Conventional treatment consists of a combination of corticosteroids and methotrexate as a first-line treatment, and it's always the case in most of the JDM. However, in our referral centers, which take several severe forms of JDM, we have observed that this combination did not allow to achieve a clinical inactive disease in 2/3 of the patient. So alternative treatments are required in some cases of severe JDM. For the last years, some targeted therapy have emerged, especially therapy which target type 1 interferon pathway. And first, JAK inhibitors have now been used from near 10 years, and these drugs inhibit the JAK pathways, with its key features of the type 1 interferon pathway. So here you may see a review of the literature of about 200 patients with muscle, skin, lung, GI refractory JDM who have been treated with various types of JAK inhibitors. In refractory JDM, this drug allow an improvement in about 85% of the children. The safety was relatively good, even if you see here adverse event is 70% of the patient, but they are mild adverse event and not always related to drugs, and they didn't lead to stop the treatment in most of the case. No cancers have been described in children. However, the follow-up of this new treatment is relatively small. And during the year 2025, several more targeted treatments have emerged and seem to be very efficient in some severe cases. First, Dazukibart, which is a monoclonal antibody anti-interferon beta whom efficacy has been reported in 3 patients with very severe JDM refractory to many treatments. Here you may see the case of an 8-year-old girl who had a severe NXP2 positive JDM refractory to many drugs, including cyclophosphamide, for 10 months. She had severe muscle involvement and bowel perforation. As you may see here, after the first infusion of Dazukibart at week 4, we observe a marked improvement of muscle score and improvement of muscle MRI. Similarly, rapidly, the bowel perforation disappeared. We have also reported the cases of 2 patients with very severe refractory JDM associated with anti-interferon gamma MSE for 5 to 6 years. In these 2 patients, the JDM was refractory to many drugs, including baricitinib, plasma exchange, anti-B treatment, and both of them have severe skin involvement and muscle involvement. And as you may see here, the skin involvement resolved in 1 or 2 months after the first infusion of Dazukibart, while muscle remission was observed in the first patient and muscle improvement in the second patient. And all these 3 patients, corticosteroids were rapidly tapered and stopped in some of them. The second targeted treatment which has emerged in 2025 is Anifrolumab, an antibody against the type 1 interferon receptor. Here you may see this publication with several patients with severe skin and muscle involvement, and again all of these patients have remission of cutaneous as well muscle disease, while corticosteroids was rapidly tapered. And finally, there are some reports of very new treatments, which are autologous CD19 targeting CAR T cells in patients with severe JDM. Here you may see the first publication of a boy who was 12 years old, was a severe JDM refractory to many drugs, including cyclophosphamide. And after the infusion of CAR T cell, you may see that at week 34, she remitted on the skin and muscle involvement. Of course, of the tolerance, the long-term tolerance of all these new therapies has to be assessed in the future. So the second-line conventional treatment has now a more limited space in case of methotrexate intolerance inefficacy, except perhaps for IVIG, which may also be used in case of mild skin or muscle relapse. Probably the other treatment will be less used in the next years. Of course, cutaneous involvement have also to be treated, and photoprotection is essential. Topical corticosteroid or protopic may be used. The indication of hydroxychloroquine is more controversial. Anyway, in case of severe skin involvement, systemic treatment has to be intensified. And the third important point in the treatment of this patient is physiotherapies, and Maxime FRICHOT will speak about this point in a few minutes. Actually, there is no effective treatment for calcinosis which works in all the patients. An approach to target patient in JDM has been published in 2025. Importantly, it is stated that at least a minimal clinical improvement should be achieved within 6 weeks after starting treatment, that a moderate clinical improvement within 3 months after the treatment, a normalization of muscle strength within 6 months, and finally, clinical inactive disease should be achieved within 12 months. Importantly, it is recommended to taper aggressively glucocorticoids and that this treatment should be discontinued, ideally within the 12 months or sooner after starting the treatment. So the identification of biomarker, which will allow to monitor or to choose the best treatment for the children, will be a major issue within the next year. Actually, we know that type 1 interferon signature or dosage correlate with disease activity in blood, skin, and muscle, as you may see here. Recently, the Mathieu Rodeo and his team has shown that muscle score, CMAS, correlate more strongly with interferon beta than interferon alpha, except MDR5 positive JDM patients. And finally, we have conducted a retrospective study in our center which suggests that a subset of patients with anti-interferon gamma autoantibodies, JDM refractory to many treatments, have a poorer response to JAK inhibitor than the other subtypes of dermatomyositis. And lastly, what is the outcome of JDM in the area of new treatment? In fact, we don't know. By experience, remission occurs in most of the patients, but we don't know the exact percentage of patients who remit and the patients who have a chronic or polycyclic course. And the mortality is very low, less than 2%, and an ongoing front study will probably help to answer to this question. In conclusion, we have seen that there has been fantastic recent therapeutic advances in this rare disease, but many questions remain. What is the role of the different targeted therapy, especially the first line in severe form, which targeted therapies has to be chosen? We have to identify some biomarkers predictive of the treatment response. We don't know very well how to treat calcinosis, and we don't know very much about the course of the disease. So now Maxime FRICHOT, physiotherapist, will speak about the important point in the treatment of JDM.
So thank you, Brigitte BADER-MEUNIER. So now I will talk about the physiotherapy with Juvenile Dermatomyositis. Just a quick word about the physiotherapy. In France, we say kinesiotherapy. Kinesis is for movement and therapy is for treatment and care. So the kinesiotherapy is a therapy to prevent, to keep and to restore the movement, the physical and the functional capacity. It's a therapy with a very large field of action. So to focus on the dermatomyositis, it's important to notice that it's an autoimmune myopathy. It's rare and heterogeneous, so it means that it's a disease with a very large symptomatology, very variable. And so for the physiotherapist, there's two types of injury that matters. It's the skin injury, which leads to a lack of mobility for the children, and muscular injury. This one is more, it leads more to a lack of strength and stamina. And what's important also is that it's a progressive disease, and it's a disease with a real potential of recovery. Progressive, so we see three phases in this disease. So the initial phase, the recovery phase, and the normalization phase. The initial phase is the one of the who comes the first symptoms. Often it's a lack of endurance, tiredness, or muscle weakness, or skin injury, calcification, these kind of things. And with the first consultation, the physiotherapist may be asked to do some muscular testing, which I will talk later. They are the CMAS and the MMT. and some very severe form of this disease may lead to hospitalization, and also during this hospitalization we may have to do some testing to follow up the progression of the disease and to see if the treatment is working or not. And we may, for some children, we do some proactive discharge and community follow-up planning. And during this phase, we recommend daily rehabilitation. The goal is to increase the functional capacity and autonomy of the children, and to do some follow-up even not in the hospital. After the initial phase, there's the recovery phase. It means that the treatment are working, and so the mobility and the muscle capacity of the children are increasing, but there's still some significant fatigability. So we recommend to pursue the rehabilitation. The idea is to work against the residual muscle impairment. So we recommend a periodic follow-up assessment to keep doing the CMAS and the MMT, notably. And we can work on the vicious posture prevention and its correction when there are some. And the muscular strength and the exercise rehabilitation are really important during this phase. And the idea of the follow-up is to help the children to return to their normal daily life and hobbies. And so after that comes the normalization phase. So it's a normalization of the test. The CMAS and the MMT begin to become normal. And but we can see some persistent axial muscle damage, notably the neck and the abdominal muscle. And sometimes there are some exercises, the conditioning that can persist too. So during this phase, the idea is to make a transition between the rehabilitation and the physical activity. So the children may do the rehabilitation by themselves, not with us. We keep some periodic follow-up assessment just for the risk of the recurrence, notably when the medical team decide to lower the medication. And so a word about our assessment with the children. There's two important parts of it. The first one is the biopsychosocial assessment, when we take interest in their daily activity, their involvement, their hobbies, and also their muscle, their objective, mainly everything that can be important for them. And we do some muscular testing, more for the medical part, like the CMAS and the MMT, which I will present to you. So here there's the MMT. This one is muscular testing to assess the strength of 8 muscle group from the neck to the foot. It's a quotation on a scale to 0 to 10. 0 means no contraction, and 10 it's contraction against strong resistance. And in the end, it's a score on 80. And after that, there's the CMAS. The CMAS is a testing which is more focused on the functional capacity of the children. So there's 14 items which evaluate a lot of different things, like can they sorry. Can they put their heads up when they are lying down? Can they take the stairs? Can they take some object on the floor? These kind of things. And so in the end, it's a score on 52. And these two tests are what we use to follow up the disease and to see if the muscle are in a recovery phase or if it's still some difficulties. And just a quick word about how to move with the dermatomyositis. It's a rare disease, so we have really rare documentation for us physiotherapists. What we have says that there's no risk with sports or physical activities. it's mainly advised to do some, but there's some risk with the initial phase when there is an inflammation, and there can be some limitation like pain, the tiredness, or the mobility restriction. What we recommend is to, during the initial and the recovery phase, we say it's better to set an agreement with the medical team and the physiotherapist to see if the children can return to physical activities or sport, and to see that together. And during the normalization phase, we say that the children can do like anything they want. There's no limitation, and if they like what they do, it's okay for us. So thank you for your time.
And thank you to all of us for your attention.